And just to introduce her, she is an associate professor at the University of Utah School of Medicine. She grew up in a military family and has lived in Colorado, Texas, Japan, and Germany. She also attended the University of Utah and completed a BS in Medical Laboratory Sciences, and then completed the Medical Sciences Training Program at the University of Colorado, and where she obtained her medical degree and PhD in immunology. Her PhD focus was on the models of allergic asthma with an emphasis on T-cell and dendritic cell interaction. She then went to the University of Michigan and completed a residency training in internal medicine and a fellowship in pulmonary and critical care medicine. She eventually moved to Utah in 2017 and joined the faculty at the University of Utah. And her current inpatient and outpatient clinical focus is on patients with chronic respiratory failure requiring mechanical ventilation due to neuromuscular diseases such as spinal cord injury, ALS, muscular dystrophy, and many other diseases. And she enjoys working with other providers such as neurology and physical medicine and rehab to care for these complex patients in a multidisciplinary setting. She also has experience managing diaphragm pacers in patients with spinal cord injuries and central congenital hypoventilation syndrome. Given her background in multidisciplinary clinics, she was involved in the building of the comprehensive COVID clinic at the University of Utah and is the medical director of that clinic, which goals include providing clinical care to patients who have symptoms from COVID, including the severe and long COVID, and to help facilitate research and further educate other clinicians about how to care for these patients. So please welcome Dr. Jeanette Brown. Thank you.
Thanks for the invitation to speak. I know I'm the last speaker, so hopefully I'll keep this relevant and entertaining for you. But please feel free to ask questions about this as well. Financial disclosure, I do some advisory board work and educational seminars for companies that are not related to this. So what is long COVID? I'm an ICU doctor, so the first part of COVID really felt like jumping out of the airplane and assembling the parachute on the way down in the ICU, where we were like, do we have enough ventilators and those sort of things? But we started hearing from patients who had COVID, who were treated at home, were not sick enough to be hospitalized, and they were like, but I'm still sick, or I'm getting sick, and this was supposed to be better. Limited testing, especially we all remember early in the pandemic, there wasn't a lot of testing to be had. Patients often felt ignored or under-acknowledged initially by providers. A lot of us were focused on people that were super sick. And the term long hauler or long COVID actually came from Amy Watson, who is a part of a group called the Long Haul COVID Fighters, who derived it from a trucker hat she was wearing actually when she went to go get a COVID test, and that's where that term actually came from. And then the NIH, when we talk about long COVID, often they will use this term called PACS, which is basically post-acute COVID-19 sequelae, and that'll be relevant for some of those studies. And so what are some of the symptoms of COVID? I will tell you so far to date, there have been over 250 symptoms that we've identified through the RECOVER trial, which is the NIH's long COVID trial. But these are kind of our biggest ones. One of them that is, I don't know, I remember being an internal medicine resident and always feeling like when a patient comes to you with fatigue, it's just a little bit painful in your soul because it could be a million things. And you're like, great, that's not helpful. But unfortunately, fatigue, kind of aches and pains, exercise intolerance, shortness of breath, neurologic issues, and I'll get into these more, but memory loss, word finding is super frustrating, and then anxiety and depression. The biggest challenge so far, though, unfortunately, is there's no definitive test for long COVID. And as the more and more we look at this, a lot of this is thinking about this as it's a post-viral syndrome. Who here has taken care of a patient with mono? Super common. It's a post-viral syndrome. Unfortunately, each one of these, though, has their own different signature or hallmark, and that's what we've been trying to learn more about as we go. So long COVID symptoms, they can pretty much impact every organ system, which is also super not helpful sometimes because it's diffuse and challenging. But the ones that come to me here at the University of Utah Clinic, though, has been primarily the people are really struggling with fatigue, exercise intolerance, and cognitive dysfunction. And usually the term they use online for a lot of these patient groups is brain fog. They just feel awful. And this is what we've seen at our clinic. We opened our clinic doors July of 2021, which sounds crazy to say out loud. Now, 1 in 5 adults nationally, we estimate, has had long COVID. And we've taken care of, these numbers are a little out of date, probably about 3,500 patients since we opened our doors. And you'll see about 67% were female and 32% were male. This has been replicated by our state of Utah data. Our health department tracks this, and also our NIH data as well. So predominantly women are being impacted. And then you can see that blue graph at the top, which basically shows you the distribution of age. We take care of patients who are 18 and above. If you have kiddos, anybody who are under the age of 18, there is actually a clinic at Primary Children's Hospital that will see these patients. But everybody above the age of 18 is primarily in that middle-aged range group, but we have seen patients all the way up until their 90s and 18 plus. And the other thing is it's not just an urban problem. We always kind of wonder about who was infected and where and the risk factors for long COVID, whether it was Alpha or Delta or Omicron. But we see actually a lot of our patients are coming from rural and underserved areas, including those with low health equity. And again, our patients are primarily middle-aged, and this can be really challenging because these are patients who are working in our communities and usually trying to take care of young families, but maybe elderly family members and a part of their community. And a lot of these folks have been had difficulty with employment and staying at their full work hours. This was a study that showed at least 40% were working reduced hours and 20% were not able to work, which is really hard. And then where are they from? We actually pulled this data when we got our state of Utah funding, but basically it's everywhere. And we are the only current clinic that is accepting new patients in the Mountain West right now. So we used to have providers, up in Idaho and actually up in Montana as well, but we've had patients as far as Alaska come to see us. So what are your risk factors for developing long COVID? From our data so far, we've seen obviously gender, female sex, middle age and older adults. We do see children that have kind of long COVID symptoms, but it tends to be a different age distribution. They also have higher BMIs and comorbid conditions such as asthma, COPD, diabetes, hypertension, and smoking. And then you had a higher risk of developing long COVID if you were unvaccinated. And so to bring this home, I like to always think about who's the patient that shows up in the office. This is a 43-year-old female. She has minimal past medical history. I always tease that people in Utah are like the sporty spice. They run the marathon, they do the 5K, they go hiking every weekend. So she was really active. She came in with a COVID infection that she had been diagnosed with in 2021. Weeks later, though, she noticed she had terrible sleep, significant fatigue. She was having palpitations, feeling sort of this, we hear this a lot, this sense of like internal vibration, chest tightness, and just poor exercise tolerance. She'd had 2 times where she went to the emergency room and she was just told that she was anxious. There was nothing wrong with her, which was very frustrating. She's gotten to the point where she had to work her less hours at work, and this has started to create some home life issues because she feels guilty. She's not doing as much with her husband and kids, and she's worried about the finances, which then makes her stress out more. And then her Apple Watch has been pinging her and saying, hey, you've been getting these random high heart rates as well. So she's really frustrated at this point, and is sort of just not sure what to do. So as I mentioned, there's always the dreaded fatigue, which can be a lot of things. A great history and physical is always great to start with. I've been sent patients before. One of them was actually having a GI bleed, which had nothing to do with long COVID. I was also sent another patient who turned out to have diaphragmatic paralysis. So really getting, just some basic evaluation can catch things that might not truly be long COVID related, but it's always something to keep on your list. We also, just get standard labs. Some of the clinics and some of the things that popped up like in the middle of COVID, people were doing these extended lab test panels, but the question is, what are you gonna do with those lab tests after you're done? And most of those now should be more relegated to those research studies. There's not really a reason to say get an IL-6 cytokine level, for example, because it costs the patients a lot of money. There are some places online too that try to sell patients on, you need this battery of lab tests. I've seen patients pay out of pocket, lots of money, $1,500 for a lab panel that, then really didn't change their management, which is kind of a bummer. But these are just kind of the good ones to get. As you guys know, iron, B12, vitamin D, TSH, CRP, sed rate, ferritin, D-dimer, troponins, pro-BNP, question mark autoimmune panel too, if they're having what could be autoimmune symptoms as well, because unfortunately in that age group and in women, you're higher risk for autoimmune disease as well. And then just really thinking about those specific symptoms to be evaluated and not missing other things that may not be related to long COVID. So this is a term that not a lot of providers at times will have heard about. It's called post-exertional malaise. And it's basically a worsening of your symptoms following physical or mental or emotional exertion that is disproportionate to the activity performed. And they usually will notice a severe exacerbation of their fatigue, their shortness of breath, and their brain fog. And how I describe this to my patients is, I live in Farmington and I have a pretty big yard, and it's about almost an acre. And so if I go mow that lawn, I'm gonna be tired. I'm gonna sit down, I'm gonna rest. But these patients, 24, 48, 72 hours later, they may have even forgotten they were exerting themselves by that point, are just pancaked. They're laying in bed, they get up to go to the bathroom, they eat, but they don't do a lot of other things. They feel terrible. And they may have a difficult time with this because unless they're keeping a symptom diary, they may have forgotten that they mowed the lawn or did the thing. And the challenge part is also they start feeling guilty because they haven't done the thing. So if they have a good day, they do all the housework, they do all the things. And so this can exacerbate this cycle of push, crash, push, crash. And, this also can overlap with the syndrome you guys have probably heard about, chronic fatigue syndrome or myalgic encephalomyelitis. That definition is more, though, based usually on multiple symptoms over at least 6-month period of time. So these definitely can overlap. So how do you manage this? Pacing, one of the things I've seen for a lot of patients, especially if they were very active before, is they really have a hard time slowing down and they want to do all the things. And so really emphasizing to them, can you get help with, somebody coming to mow your lawn, for example? Can you get rid of the activities that you don't necessarily want to do and prevent those exertional crashes? Monitoring their levels of activity is key. Upright exercise can also be a trigger. So we initially, if you're going to start exercising them, we actually will use a recumbent or semi-recumbent exercise such as rowing, swimming, or cycling to help them keep some exercise component. And then individualizing the exercise programs, one size does definitely not fit all with this. And really starting with slow intensity exercise, gradually increasing exercise tolerance. We're talking like 5 to 10 minutes per day of recumbent exercise, and increasing those slowly by 2 minutes a day per day per week. The other thing is this can be really difficult to manage, and they may need a lot of support. And so some cognitive behavioral therapy has been shown to help as well. This can help reduce fatigue and also improve concentration and help to manage the psychological stresses of coping with a chronic illness. And then symptom management, again, insomnia, mood disorders, and chronic pain. I'll talk about some of those things in a bit. But it's key for these patients also to maintain their hydration, because one of the biggest triggers for this can actually be POTS. And then, trying things and having people keep a symptom diary and then saying what's working, what's not, can be really helpful for them to take control of this. So another condition we see a lot of is postural orthostatic tachycardic syndrome, or POTS. One of the biggest challenges I found with POTS is it kind of lives on the fringes of like cardiology and neurology, and depending on where you are, some providers won't manage it, some providers will. But it's part of a broader spectrum of autonomic dysfunction, and we're seeing quite a bit of this in long COVID. This will keep patients, crashing again And this will keep them coming back and just being like, I feel terrible. But the key of the definition is you're going to have a big heart rate jump within 10 minutes of standing without dropping their blood pressure, systolic drop of at least 20 or diastolic. And their heart rate, the way to do this test is you basically have them stand up. I'll have them take their shoes off because as you can see from the picture, this becomes kind of obvious at times. But you do their heart rate and blood pressure when they stand up, 2 minutes, 5 minutes, and 10 minutes for the test. And this is what it looks like often. You'll see pooling. And this also can actually trigger symptoms of patients like in your office in front of you. They're like, I don't feel so good right now as they're standing. And basically their autonomic system has forgotten how to regulate their blood vessel tone. So it can also be associated with symptoms like that fatigue, shortness of breath, a brain fog, the palpitation, like in that case report I talked about, and then lightheadedness and exercise intolerance. And this is one of the big ones that will drive patients to come see us. So what do we do about this? If POTS is mild, you can actually start with lifestyle modification. Increased fluid and salt intake is key. A lot of these women tend to be young. They tend to have lower blood pressure. So, having them, they can use some of the over-the-counter electrolyte solutions like liquid IV. You can have them eat a lot of ramen. It's not the greatest health food, but, just as long as they're getting a decent salt load. The other thing that's helpful is because a lot of the athletic clothing now for compression's so much better. I have them wear compression stockings at the very least, but then they're more like total body compression garments, but that can really help with that blood pooling problem because a lot of it's like positional change. They get up and they're like, oh, I feel dizzy and now my heart's beating out of my chest. If I have a patient that's in a really bad flare, though, I can do just some IV saline, normal saline, and that can help them sort of eke out of that crash. But medications for POTS, so beta blockers are usually the place we start. The challenge I have with them is that I will usually start low dose propranolol. And this can actually help people, though, who have coexisting migraines or anxiety as well. The challenge with both the beta blockers and your calcium channel blockers is how much heart rate room do they have for this and how much blood pressure range do they have for this? Because if they're already starting on the low end of normal, that can be problematic and they may not tolerate it. Just pre-COVID, though, ivabradine, which is a funny channel, is the mechanism of action. That one actually works pretty well. Unfortunately, I find insurance companies don't love it because it's more expensive, so they'll make you fail a calcium channel blocker or beta blocker prior to that. But a number of our patients do improve with from a heart rate management and quality of life standpoint. Your other options also include fludrocortisone. Taken at night can help with blood volume and the orthostatic issues, but you have to monitor for the hypokalemia with that one. And then midodrine, again, increasing your vascular tone and improving symptoms of that tachycardic response. The other really big one that I hear of is the brain fog. And really what brain fog is, it's a constellation of symptoms. They can feel a lot of anhedonia. They have a lot of dissociative experiences like, what was I doing? They have forgetfulness. I've heard of people putting their remote in the fridge, for example, like doing just odd things that they wouldn't normally do. They have difficulty with concentration. This can really annoy them at work and other high cognitive load tasks. Word finding, though, is one of the biggest ones that drives people crazy, too. They'll be in the middle of a sentence, and they can describe other things, but they can't find that word, and it just bothers them. And then when these all overlap, it can just really cause a lot of distress for patients. So this is interesting, too, because in my ICU world, post-ICU world, we're used to patients having a lot of cognitive dysfunction after they've been in the ICU. And this was actually the Great British Intelligence test that they did. These were 9 cognitive batteries that they had lots and lots of patients take in the UK. It just happened to overlap with COVID. So when they went mining the data, you can see the bars on the right-hand side. people that were really sick in the hospital, their cognitive function declined. You can see that impact there. But even being at home with respiratory symptoms alone with no assistance, you could actually see impairment in their cognitive function on these battery of tests. And this was done just blinded. They just gave some medical history, so they were able to pick out this signal. So it definitely is a real phenomenon. So how do you evaluate for it? Again, I'm always usually asking them for post-exertional malaise, symptom diary, those sort of things. I'm looking for POTS. Autonomic testing is key there as well. I will say, though, that if you do a tilt table test, they can be hard to get somebody in for a tilt table test, but they can also flare their symptoms. And so I really reserve the tilt table test for the patients where I'm like, I don't know if you really have this or not. But again, evaluating that symptom diary, if they're at age where I'm thinking of other cognitive dysfunction, you can look at a MOCA. Getting more complex cognitive assessments, especially like neuropsychiatric testing, sometimes may be appropriate. The biggest challenge is it's often, like at the university, it's a year waiting list to get in. Can be really, and those tests, by the way, can make people have a flare because it's like an 8-hour battery of tests. So there's always, moments where I'm like, are we going to do anything different for this if I have this diagnosis, is usually why I tend to send people off for evaluation. And then there's the functional and symptom surveys like the Compass 31 that we can assess, but we're primarily using that one actually for research. And then for treatment and support, because of my background with working with spinal cord injured patients and traumatic brain injury patients, stroke, I'm used to using actually speech therapists to help them with a lot of those difficulties. There's actually post-concussive therapy that speech therapists will do. Usually I have to find a specialized one, but helping to assess what their cognitive deficits are and then give them coping strategies can actually reduce the frequency of their triggers for like post-exertional malaise. It tends to reduce their anxiety and frustration with it, which can be really helpful. And then what's been recommended in the guidelines so far is physical and mental health rehabilitation, and similar to what's been done for chronic fatigue, depression, and post-concussion. So even though long COVID is kind of newer, we can borrow some of these resources for other things, and really trying to get to the root of other issues that might be triggering their brain fog. Another thing that has popped up is mast cell activation syndrome, which is basically where your mast cells release inappropriate and excessive mediators from those mast cells, and then unfortunately can affect a lot of systems, the cardiovascular system. You can see skin findings, respiratory and GI manifestations, and again, this can exacerbate that fatigue, the brain fog, and the autonomic dysregulation. I feel like a lot of these are like kids in the back seat. If one isn't happy, the other isn't happy. They just sit and poke each other. So really getting a lot of these evaluated and calmed down can make a big difference in your patient's functionality. And using empiric treatment with antihistamines, including your H2 blockers and histamine blockers to start with. I usually use the non-sedating ones. And then if you need to, you can actually go to mast cell stabilization. Referral to allergy immunology also could be appropriate depending on how much they're struggling with some of these symptoms. And there is an overlapping syndrome that we have seen. So Ehlers-Danlos syndrome, the typical patients I always think of are the extra bendy ones that have really loose joints and skin. They have this hypermobile phenomenon, but it's proposed that they're predisposed to dysautonomia, including POTS already, and then they already have the underlying connective tissue abnormalities, which may exacerbate this. And so it's a little bit egg and chicken for some of these patients as well. And some will come in and tell me, oh yeah, I had mono as a kid, and it's like their second round of a post-viral syndrome that they're just probably more predisposed to. But we have actually seen an increased incidence, though, of abnormal heart rhythms with them as well. So it's also a good idea to consider a Holter monitor in them as well. And then, of course, they can have the mast cell activation syndrome just to add on top of it. So I'm going to talk about treatments here, but one of the big things I get is a lot of people come in and they want to try the latest thing off the internet, or they've heard about random treatments, or they want to pay for this or that. And I'm always like, let's have a shared decision-making discussion about the costs, the potential benefits, but also the risks. because I don't think sometimes patients think that way. They're just, really desperate to feel better. And so one of the biggest difficulties I have is that I've had patients fall for scams. I've had people end up, actually with vitamin toxicity because they're, more is better. And so I'll take more supplements. And so we really have to be careful with like the information and the latest trends sometimes to make sure that we're not missing some of these patients, like what these patients doing may be harmful to them. And so I tell people, tell me about your supplements, tell me about what you're doing during your day life. You just want to make sure that they're not going to get hurt by doing something that they don't understand could hurt them. So treatment for long COVID is multifaceted, and it really depends on your specific symptoms. I have my patients tell me, what's the most bothersome thing to you? And that helps me prioritize what we treat, because if you overwhelm them too by having lots and lots of treatments, they may not be able to do that. We try to take a holistic approach with physical and mental health rehabilitation. Our physical therapists and occupational therapists do a combination of teaching pacing and adaptation, recumbent exercise. And then, as I mentioned earlier, speech therapy can do a lot of cognitive retraining for patients, which can really help. And then treating their POTS if that exists, or mast cell activation, also is really key. One of the things you may see is low-dose naltrexone. There have been some cohort studies with reduction in symptoms, a number of symptoms and improved symptoms. There's a randomized control trial both in British Columbia that's in process, and also RECOVER, which is our NIH trial. There is also an arm for that they're looking at it. But you have to remember, currently this is off-label use, and this can be costly for patients. In my clinical experience, I think it's kind of hit and miss. Some people say it's great and it really helps them. Some people say it doesn't really do much. But it can have sleep issues, which is already unfortunate because they can have sleep problems, GI symptoms, headache, and dizziness. So it's important for people to keep a symptom diary. You also may have heard of this. This got some press as well. It's called a stellate ganglion block. You can get these through pain clinics. It's a procedure basically where they go into the stellate ganglion with a local anesthetic, and that helps to block the sympathetic sort of overdrive is kind of the idea. This has actually been done to manage pain and other conditions like PTSD, but that is actually also considered off-label. So most of these will not be covered by insurance. There current evidence to say that it might be helpful is kind of at the case series level, but it's one of those things that as long as they're going to a reputable pain clinic, it is something that they could consider trying. But again, it's going to be out of their pocket, which is a bummer. So looping back to our patient, our 43-year-old lady who had minimal past medical history, who was super active, she, after her COVID, weeks after, developed a lot of symptoms. She came in and her feet looked exactly like the picture that I showed you with POTS. She had significant POTS testing without the orthostasis, which is key. Her feet were purple. We actually did a Holter monitor, but primarily what we were seeing was just sinus tach. And then we had her start with compression clothing, increased salt intake. We tried the propranolol, but unfortunately she had issues with her blood pressure going too low. But then her insurance would pay for the ivabradine, which actually helped her quite a bit. And then we worked with her with our PT and OT. She did things like, hiring a gardener and other things to do activities that she wasn't that interested, so that she could reduce the risk of her flares, which was really helping. And then she actually, as we started talking more, was noticing a lot of brain fog and difficulty at work. So we worked with speech therapy. We did some coping strategies and cognitive load management. And then this was quite a bit better. And what I found clinically is once you can get people out of this push crash cycle, once they start getting better, you'll see slow and steady progress. And that made a big difference for her. And the question we always get, and I always say my crystal ball is on the fritz, is how long is this going to last? That's a great question. The mean duration when you look at long COVID data was 4 months, but a significant proportion of them continue to have symptoms beyond that time frame. If you looked at the data that came out when they looked at people at 12 months, about 15% of the initially impacted patients were still having symptoms. And in a prospective cohort, only about 23% said they were completely back to normal, back to 100%. How I've had my patients tell me is, At about a year, for example, they're like, I'm like 85 or 90% better. But, usually, enough that they feel better, but it's not 100%. So that can be challenging that way. And then prolonged illness risk factors include gender, female sex, older than 50, and then, of course, pre-existing conditions to go with that. And then this is the other thing we're seeing, too, is I was feeling great. I was back to about 90%, but now I'm sick again. Long COVID symptoms such as brain fog, fatigue, and POTS are likely to worsen with a subsequent COVID infection. So you'll talk to somebody, it's like, I'm on my 5th round of COVID, and every time they get another round, they feel like they take steps backwards and then they get better. And it can be even also an infection that's not COVID. And sometimes you get the existing symptoms that get worse, or they can get new symptoms or ones that had resolved come back. And so it's just important to look at the tools and, kind of reevaluate to see if they need to go back to, say, pacing or adjust medications or do other options to get back on top of their symptoms. Because this is a learning process for all of us, including healthcare providers, we have a Project Echo at the University of Utah. If you've never looked at any of the Project Echoes, these are really awesome. There's a lot of different ones. There's an infectious disease one, there's a pain one, there's lots of different ones. But these are basically monthly didactic sessions where we get on in partnership with the Bateman Horn Center. These are no cost to participate. This is what I refer to as lunch and learn. Because we do them at noon here. And we also give you free CME, so it's definitely worth, but we'll take a break for the summer, but then we'll get back on track. But we have basically come at this from a lot of different different angles. We had and these are also recorded online, so if you want to go look through the old ones, you're welcome to. One of the ones we found really helpful was like disability paperwork and some of the other things that come up from a psychosocial standpoint, physical therapy options, occupational therapy options as well. The ones coming up are going to be pediatrics and young adults and navigating sleep challenges. So we were lucky that the state of Utah gave us some leftover CARES Act money and FEMA overpayment to the state. The University of Utah Clinic is funded to see patients who are uninsured, underinsured, or out of network for the university, aka Select Health. And we can cover up to $5,000 of their out-of-pocket costs up until December of 2026. So if you have some patients that you're struggling with or want a second opinion of, we are definitely happy to see those folks as well. And we're usually booking within 1 to 2 to 3 weeks, depending on the time of year. So we were really lucky to have that, and hopefully we can get some funding beyond that, but we will see. And then our clinic resources, we get an hour-long visit with each new patient, and our follow-ups are anywhere from 30 minutes to an hour, depending on what they need. We can help with POTS management, which is one of the challenges because it kind of does live between, neurology and cardiology. Some providers don't love to manage that, but we have specialized OT, PT, and other subspecialists available through our clinic. So happy to take those referrals. And if you have an interest, sending a patient, you can actually just Google University of Utah Long COVID Clinic, or this is the fax referral, or if you have any questions, this is our back line. We're happy to take questions. One of the questions I do get is, do you require a positive COVID test to see a patient? And the answer is no, because there were a bunch of times during the pandemic we didn't know. So what are we doing about this? The University of Utah is actually also an NIH Recover site, which means we enroll patients for both a prospective symptom evaluation, but also clinical trials. Currently, the NIH has 8 clinical trials that are active, and we're actually part of the Energize trial. And then beyond that, you can actually, or patients themselves can actually submit potential therapeutics to Recover. There have been 530 basically submitted so far, and at least 40 of those are going to go into trials as well. That's if nothing changes with Recover's funding. We'll see. TBD. But in summary, though, long COVID can be challenging, but we do have things that we can do to help patients. This usually occurs months after the onset of infection, and they can persist for months or years. And then common issues we're dealing with include brain fog, fatigue, the exercise intolerance, and many more. And then post-exertional malaise and POTS are 2 big ones that are challenging, along with mast cell activation syndrome. But we find if we can start to manage these better, along with their other symptoms, that they will get better over time. And then likely multiple mechanisms have been evaluated, and clinical trials are going to be ongoing, I think, to better understand this. Cool. Well, take any questions.
A couple questions. One is, I'd really hesitate to use propranolol in people that have exercise fatigue, because propranolol, you know, limits your heart rate, makes you feel tired, decreases your sex drive.
We use low-dose propranolol, but it's still, to be honest, most of that is because insurance companies won't give me ivabradine to start with.
And a selective beta blocker wouldn't work?
So far, we haven't seen, improvement with that. And exactly why ivabradine works better than, say, the calcium channel blocker or beta blockers is still sort of being looked at. But it was even shown in a study pre-COVID that it was better. But yeah, it's kind of challenging so far.
And the exercise that you recommend, do you think that that changes the progression of the disease, or is it just to control symptoms? Because I exercise, I push myself to do it, but I wouldn't want to get out of shape, which I would if I did those really minimal exercises.
Yeah, it can be really hard because if you go to like a traditional work to exertion sort of thing, then it makes them worse. What we found, though, is by using that kind of recumbent exercise, they don't get that pooling and draining effect. So recumbent biking can be helpful, and some of the other things that we use in our physical therapy clinic. But that's kind of one of the quirky things about that. But you want them to be able to do something, hopefully. Otherwise, yeah, you will.
So even if they don't have POTS or anything like that, you still
it's primarily for the POTS sort of folks, but if I'm not sure if they have more of just that general dysautonomia, I will start them with that. And if they tolerate that, then we can progress them to standard exercise.
Thanks.
Any experience with using Provigil for fatigue? And then second question is, I had a patient ask me about tacrolimus. Do you know anything about that?
Tacro, again, sort of that shared decision-making thing. I'd be really hesitant considering all the potential risks associated with that. I think it was one of the many items that were submitted to Recover as maybe something to look at. But again, I don't think I would do that outside of a clinical trial, just given its risk. And then your other question about Provigil. It's a stimulant, obviously, to be honest, with patients with brain fog, they've actually, a lot of them found it worse. The other cousin to that is like Ritalin, things like that. So if anything, I've tried to help them sleep better with better sleep hygiene, things like that, but also controlling like their mast cell symptoms. Some of the things may be actually related to that, mast cell post-exertional malaise, and really digging down into those as well. But it's one of those things that's worth a try, but I'm not had as much luck with it as I would have hoped. But great question.
So my question's about the vaccine. I would assume that vaccination in this patient population becomes more important, but I wondered if that's been looked at.
Yeah, so they looked back at a bunch of data where, because like, for example, I was one of the first people to get the shot, right? I've had 6 vaccinations now. But looking at people who had had multiple vaccinations were much less likely to acquire long COVID or any vaccination versus people that were unvaccinated. So yeah.
And then I could see my patients, when I recommend it to them, ask me if it's going to make them feel worse, if that's been looked at.
Yeah, usually I warn them about like just the initial vaccination component of it, but typically there are some patients that I think are potentially just more hypersensitive, but one of the challenges is like you'd have to have a good symptom diary before you got the vaccine to know. But there's been no data though to say that it consistently makes people flare, and some of my patients actually say it makes them feel better. So great questions.
There was a study done out in, I think it was Europe, on the rates of myocarditis from the original COVID virus versus the vaccine, showing that the vaccine was far less on its rates of myocarditis. I didn't know if there's better research that you've seen since then, because that study is about two or 3 years old, because that's a big concern with the vaccinations. And I have patients that will say, no, and I tell them, look, I've been vaccinated multiple times, et cetera. This is what I'm doing personally. I cite that study. Do you know of any others that have come out on the relative safety of the vaccine versus the real deal?
Yeah, part of that is from Recover. We have newer data that basically verifies the same thing as that prior study, which was if you have actual real deal COVID, you're much more likely to end up with myocarditis, which, by the way, if you look at the patients that did get vaccine-associated myocarditis, I think if there was like 1 or 2 cases that had any persistent symptoms, so it was a very transient thing versus the like true COVID cases. There were a lot more severe like outcomes and the persistence was longer. So
Great.
Yeah, I agree with exactly what you say is basically what I say.
Thank you. The last question is, how do we keep from referring like every patient I see in primary care to you? Because the number of patients who come who say, I'm feeling fatigued,
Yeah.
you know, a little bit of joint aches, I'm doing blood work, there's no rheumatologic evidence of systemic inflammation, there's so much prevalence of this kind of, you know, chronic fatigue, which overlaps with COVID. If I do the antibody testing, not just for the presence of previous vaccination, but for were they infected, they're all positive. So like,
How do you go through that?
Yeah.
What I would say is, you know, do your evaluation for POTS, evaluate their symptoms for post-exertional malaise, look for the mast cell activation syndrome. Those are kind of my biggest thorns so far. And if you get to a point where you can't get anywhere with those are great patients to refer.
Okay, thank you.
Yeah.
So I saw an article made from the local VA, and the COVID clinic there. The gentleman was saying that they were seeing much better prevention, I guess, of long COVID in those who use Paxlovid during that time.
Yes.
Have you seen that too?
And that's true. Paxlovid, the challenge is it's not for everybody. Not to mention it interacts with a lot of medications, and it has a terrible taste side effect. But yes, that is true. It's like if you blunt that initial inflammatory response, the challenge is like to be able to do that kind of study or treatment going forward, you'd have to catch people right in that window. Same thing with Tamiflu. And then everybody would have to have it. So there are, though, in that Recover trial, a bunch of antivirals that they're looking at for long COVID. Is one of the theories is viral persistence in, you know, same way with shingles, for example. It's like you have a viral reservoir or something and this keeps annoying your immune system. Is that a possibility? So we're looking at that with the autopsy studies, but also with the Recover ones.
So secondary, I've had 9 shots for COVID since it started. I've had 1 breakthrough that lasted for 5 days. Not a big deal, and I'm 75. Just a week and a half ago, I heard a news blip that the new CDC director, in spite of the fact that we all know that 30% of the country never got any vaccinations for this, when asked by a reporter at, I think, her initial press release, was asked about COVID, she said, "Oh, that's so yesterday. That's a Biden thing. We're not worried about that now." And yet I keep seeing stats that look somewhere between 500 and 1,000 deaths a week.
Yep.
In this country with what, 17% of people have had the latest booster for Omicron, which is actually easier to get. I mean, I don't know how we fight this craziness in the political realm because people are not listening to us. And I talk this every day of the week to all the people that I intake. I'm saying, do you have your COVID vaccines? But it's an immediate red flag for a lot of people, and I don't know how to deal with that. I keep trying.
Yeah. I mean, I think our patients who are suffering with this would argue that it's not yesterday, unfortunately.
Yeah.
And a lot of it, though, is I think I get frustrated by it too. You know, I'm worried our federal funding for research studies is gonna get cut. But the thing I always take away though is that patients that we see though, when they develop trust with us though, will take that to heart, like especially on other things as well. You know, they trust you in your opinion as well, and you're just say, you know, I'm looking out for your best interest. You have to ask about some of those other people, whether they care about your best interest.
I'm still fascinated by the idea that this, when you look up the stats, the 1918 flu ran about 650,000 deaths in those 2 years. This one's up to 1,022,000 and shows no sign of letting off, you know, like we did when we saw it in the SARS epidemic. So I don't know why we're not characterizing this as the worst thing that ever happened to the country as far as an infectious disease with death.
Yeah, I'm an ICU doctor, and I had a patient within the last 6 months in the ICU die. They had other comorbidities, but yeah, they died. So, unfortunately, it's not gone. Sorry. Thanks, guys.